Gotta get on. I know. I think you all know me, but I'm Jackie Lawrence, and I'm the Director of Nursing Excellence for Blue Ridge Healthcare. And I'm very excited about having Dr. Zook here, our spine surgeon. Can we do a big yay? Yay! And he's here to help us understand what he's going to do to his patients and then how we will take care of them. Sometimes I think that the cool part is understanding what he does, because that'll help you understand how to take care of his patients if you know what they've been through in the OR. So if you can give him your attention this morning. This is Dr. Jason Zook, and can you show him some hospitality this morning?
Thank you. It's nice to meet everybody here. Hopefully I'll meet you guys, and if I have to ask your name more than one time, please don't take offense. I'm not the best with names. But again, my name's Jason. I'm coming here from out near Virginia Beach area. I've been in the Navy for the last 6 years active duty, so I'm just wrapping up my time with them, and I'm very excited to be here. Moving here with my family, my wife, my 3-year-old, and we have another one due next month. So if anybody spends any time on the labor and delivery floor, you guys will see us there next month. But they asked me to come and talk to you all about postoperative care of spine patients. Spine patients can present some unique challenges at times. Generally, everything goes pretty smoothly and like clockwork, but if you don't pay attention to some little things, you can miss something major. It can be a big problem. So they asked me to kind of go over that, and so I thought I would just give you a little bit of a background of some anatomy relevant to the spine. We'll talk about some common surgical diagnoses. In other words, what are the reasons why I'm operating on patients that they're going to come to see you. We'll talk about some red flags. What are some things you need to look out for when taking care of these patients? The evaluation, some basic evaluation techniques that you need to employ when taking care of spine patients that may be unique compared to someone else that you may be taking care of. For example, maybe a hip patient or a general surgical patient. And then finally, some common post-op orders, and this is kind of like the world according to me, right? You've probably taken care of spine patients before, some of our other providers. These things are not necessarily the right way to do things, but these are just the way I'm used to doing things, and I would like them to be done for my patients. So this doesn't necessarily mean I think this is the only way. There's certainly other ways, but these are the ways I'm used to, I guess. So basically, the anatomy. The vertebrae, those are the bones of your spine. Okay, we have 7 cervical vertebrae, 12 thoracic, 5 lumbar, your sacrum, and your coccyx. This is your sacrum down here, okay, and this is a little tip right there is your coccyx, okay? And you can see that our spine is curved, okay? We call this lordosis, okay, the sway back. We have lordosis in your cervical and lumbar spine, and we have what's called kyphosis, or people call cat back, in your mid-thoracic spine. And the spine is curved in a way to provide balance so that your head sits right over your pelvis and that you stand upright, okay? And that's the design of the spine, okay? The bones, more specifically of the spine, this is an example of a vertebra here, okay? And it comes into different components. We have the vertebral bodies, which is the main big part. That actually bears 80% of the weight of the body. The weight that comes across there goes across this part. And then we have what things called the pedicles, the facet joints, and the spinous processes. Don't worry, we're not testing you on any of this, okay? But this is just showing you some of the bony elements or bony anatomy of the spine. And this is a side view of the spine here. And you can see that these bones stack up on top of each other. This white part here is the disc, the cushion, okay? And when they stack up, they provide little holes right here, and that's where the nerve roots come out. This right here is where, depending on where you are in the spine, where the spinal cord would be sitting. And when you get low enough, this is where the nerve roots sit in the spinal fluid sac, okay, called the dura. At each level of the spine, we have 3 joints. The joints are formed by the disc at one point, and then we have facet joints here and here. And the facet joint is basically where the one bone meets the other bone. And the idea of this is to help allow motion, but not allow too much motion, prevent it from going wibble wobble, okay? If we didn't have these joints, we would have what's called an unstable spine. Sometimes we get trauma patients that fracture one or more components of this, and they have what's called an unstable spine. In other words, if they got up and tried to walk, it would slip off and we'd have a problem. Sometimes we have to surgically fix these things, okay? So this is the way God made us, okay, to have these joints here to allow motion and to not allow too much. So what are some surgical diagnoses and treatment? Okay, this is actually a picture taken when I was in Afghanistan a couple of years ago, taking care of a patient who had gotten shot through the chest. But anyway, these are some diagnoses. Hopefully we won't see too much of that here, right? But some diagnoses we see. Radiculopathy, that's compression of a nerve root. Stenosis, that is compression on nerve roots or the spinal cord, depending on where you are. That's the canal being narrowed. We'll go over these in a little more detail in a minute. Instability, so we talked about, right? Instability is unstable spine. Spondylosis or degenerative disc disease. Now, this is kind of a controversial topic as to whether it's good to operate on degenerative disc disease or not. It's all over the news lately or in the internet. We'll talk about it just very briefly. And then some common treatments that we do. Decompression infusion, disc replacement. Okay, these are some of the common things you'll see patients come up on the floor. Okay, some surgical diagnoses. So radiculopathy, that's pressure on a nerve root after it's left the spinal cord. Okay, so we call that peripheral compression. Okay, it can occur in any of the nerve roots. It's most commonly seen in the lumbar spine. Okay, L1 through L5. Okay, and that has to do with the anatomy of the spine, the relative amount of space available for the nerve root, and also the size of the nerve roots. As we get further down the spine, the nerve roots get bigger, and the space for them gets smaller. So it only stands to reason that if you have a smaller space, the straw that needs to break that camel's back doesn't have to be quite as big as it needs to be up a little further higher up. Okay? So the lumbar is the most common region, followed by cervical and then thoracic. And this is just a picture here demonstrating some of that cushion squishing on the nerve root. The disc, or the cushion, the outer part is tough like a rubber tire, almost like a car tire, okay? And the inner part is described almost like a jelly donut. It's a little bit thicker than a jelly donut, but it's the idea of it is that this cushion here, that cushion in the center allows for the compression, and then the outer part is tough to prevent when you twist so nothing rips then. But sometimes we get a rip in this part of the tire, or in the radial part of the tire, and then this jelly is allowed to squish out. And then that's what puts the pressure on the nerve roots. Okay? So what is radiculopathy? So I mentioned to you is pressure on a nerve root. What does that cause in terms of a patient? A person doesn't come to you and say, I have a radiculopathy, right? Most often. They say, I've got pain, or I've got numbness, I've got tingling. Generally, one nerve at a time is getting squished. You can get more than one nerve at a time getting pushed on in radiculopathy. You could have multiple discs, but generally it's one disc that presents. And so it's one nerve root that's getting pushed, and therefore it's one nerve root distribution. Okay, we call that a dermatome. Okay, that's the area on the arm or the leg that the nerve represents function for. Okay, each nerve root has a specific task. Some nerve roots work together. For example, the biceps, we use C5 and C6 to help the biceps. But for generality terms, each nerve has kind of a purpose, and it has certain nerve muscles that it works in a certain area of the body that represents sensation on the body. Okay, so we mentioned C6 a minute ago. Well, C6 has sensation here and into the thumb. So I know if a patient comes and tells me before I even look at an MRI or an X-ray, if we start talking and he's got weakness in his thumb and numbness and tingling in here, that's probably a C6 problem. Okay, so a lot of times we don't even need these MRIs that we seem to get a lot these days. But anyway, so that's numbness or tingling and pain and nerve root distribution. Okay. So what does it mean? It's a single nerve root. It's a single dermatome most often. What is this not? So if someone complains of an entire arm being numb, entire leg being numb, it's probably not from a disc herniation on a nerve root. It doesn't mean that they're faking or that they don't have a problem. It's just probably not this particular problem. What are some treatments? There's many things. There's lots of non-operative types of treatments that we do first. But your concern is today, well, what would I be doing for a patient that would bring them to you? So surgical treatments for radiculopathy include a discectomy. That means I'm taking a part of the disc out that is pushing on that nerve root. So we saw that picture earlier of the disc that's pushing on that nerve root. And that's all we really do is we go in, make an incision, remove a little bit of bone away so I can get down to that disc. I have to pull the spinal fluid sac and the nerve root to the side, and I cut out that disc that's pushing the nerve root. Okay? About 30 years ago, we would take that entire disc away. Okay? And the good thing about that is that we never had a repeat herniation, right? Because the disc is gone. The bad thing we found out is that we have no cushion left. Guess what? You progress to arthritis pretty fast. So we realized that's not the best thing to do. So we've kind of moved away from that, and we've gone to doing a small amount of discectomy, just taking the part away that's causing the problem. The bad news is that you could always have a repeat herniation in the future, but the good news is you've got that cushion, which is what you need. And so most people feel like that's a pretty good trade-off. There's micro, if you hear someone's had a microdiscectomy, I do a lot of microdiscectomy. All that really means is that a microscope has been used to allow for a smaller incision. Okay? The procedure is still the same. There's nothing fancy about it, excuse me, except for the fact that we just make a smaller incision. I use a microscope, almost like you had in biology class before, looking at slides. It's kind of like that, except it's a little bigger, a little fancier. I have to look down and make everything zoom in for me. Okay? Laminotomy, laminectomy, you'll hear these terms. A laminotomy basically means a small amount of bone is removed, and a laminectomy is a complete one side of the bone is removed. Okay? So these are just different fancy terms of just talking about how much bone is taken out. Okay? The bottom line is that some bone usually has to be taken out to get down to the disc space. Okay? Now, sometimes with radiculopathy we have to do a fusion. It depends on where we are in the body. For example, in the cervical spine, if I decide to make an incision in the neck to take that disc out, to put pressure, that's putting pressure, there's no way to get just a part of the disc out coming from the front of the neck. I have to take it all out because it's pushing behind on the spinal cord. So whenever you do that, you have to put something in its place. And that usually means traditionally a fusion or a disc replacement. Okay, so sometimes with radiculopathy, you do end up getting the whole disc removed, but usually that's only the cervical spine. All right, so the next surgical diagnosis you're probably going to see is stenosis. Okay, so this is the canal, or the space here in the central part of the space for the spinal cord or nerve roots, depending on where you are. The spinal cord ends at around T12 or L1. Okay, this space gets narrow for various reasons. It can be narrowed because of big, huge disc herniation. It can be narrowed because of the ligaments that are back behind here start buckling in. Okay. It can be because we get a cyst that comes off this joint, or bone spurs. It can be a combination of all these things depending on the patient. But when this gets tight enough and small enough, people start developing symptoms of this. Okay, and depending on where you are in the body, whether it's getting pushed on nerve roots or on the spinal cord, different symptoms can appear. In the cervical spine, if you have pressure on the spinal cord from stenosis, it's called cervical myelopathy. And myelopathy refers to the fact that your spinal cord has got compression and is not happy about it. Okay. In the lumbar spine, it presents usually as neurogenic claudication. Okay, and that's a fancy way of saying leg pain and calf pain, leg weakness. The classic thing is you'll see if you go to the grocery store, you go to the shopping mall, and you see people leaning on the grocery cart as they walk down. You may know someone who does that. Okay, parents, grandparents, someone like that. And the reason being is that when you lean forward, it allows a little bit of opening and widening of that canal. So not a lot, but a little bit, and that's enough for a patient so that it gives them a little bit of relief. But basically what happens is these nerve roots get pressed and people start getting leg pain, fatigue, cramping, can't walk as far, you have to stop, these types of symptoms. Okay? Thoracic spine stenosis is uncommon unless it's congenital, which means born with it, although it can happen. Treatment, again, most treatments we always initiate are conservative at first, but again, we're talking about what's going to happen when you see them. And so decompression is usually involved for stenosis. Sometimes decompression is enough that we have to also fuse them. Again, lumbar stenosis, more common than cervical. There's more space available for the spinal cord up high in the cervical spine than there is space for the nerve roots down low, and it's just anatomical, it's just the way God made us. Okay? Again, neurogenic claudication, that progressive tiring, cramping, numbness of the lower extremities when you walk. Okay, the grocery cart sign, like I mentioned. There's other things that we could talk about more, but those are the classic symptoms. Cervical myelopathy, what happens is you can get all that claudication symptoms, but in addition, people usually complain of some clumsiness, some difficulty. People will say they have trouble with doing buttons or zippers. People maybe are long-time sewers. They can't really hold the needle as well anymore. People may tell them that their handwriting is changing because they can't do fine motor skills as easily. Okay, that's a classic or hallmark sign of someone with spinal cord problems. Okay, people walking, wide base shuffling, things of that nature. So what are the treatments? Again, we're taking the pressure off. So I mentioned to you the problem with stenosis is that we have a small opening. Well, it's not really rocket science, we just need to open that up, right? So what we do is remove a portion of the bone or a lot of bone, depending on how bad it is, to open up the roof. And the analogy I give to patients is you can imagine living in a house that your roof is progressively shrinking in on you. And you started out with 8-foot ceilings, and now we've got 5-foot ceilings and 4-foot, and next thing you know, you're like Alice in Wonderland in a small little house. And so what we do surgically is we're just taking the roof off the house. Okay, we've made the car convertible, and that's all we're really doing. There's nothing magic about that, but that is enough for the nerve roots in the spinal cord a lot of times to breathe a little easier, to expand back up, and to make you feel better. Okay. In the process of doing that, sometimes we destabilize the spine. We have to take so much bone away that the spine is no longer stable on its own, and that's when we have to add the fusion in. Okay. So instability. Okay, as I mentioned, this is the spine. This is an example here of what they call a perched or jumped facets here in the cervical spine, probably from someone who had a car accident or a fall or something along those lines. Okay, this is an unstable spine. And as you can imagine, in the cervical spine, when you get something like that and the spinal cord's there, that's a problem, right? And this is where you see sometimes people come in who are quadriplegics, right? And they've lost all the function of their arms and they've lost the function of their legs because of spinal cord injury. So this is a serious condition when we get instability in the cervical spine. And it can be very serious in the lumbar spine as well. There's different things that can, different types of instability. The first one, as I mentioned, is traumatic, okay? Pathologic means a tumor or something else has gone on in the body, tumor or infection most commonly, okay? That has eroded away into the spine and the bony elements, and now the spine is unstable. Degenerative, this is the most common, okay? And the most common level we see for this is L4, L5, okay? And this is a slip in the back, or people will come in and we'll see this, I'll get these x-rays, I'll stand them up and get x-rays, and we'll see the spine, the normal alignment that we looked at this slide earlier, a nice kind of curve of the spine. If you look at the front of the spine here, draw a line here, you see that there's a little bit of a step off here. We call that a spondylolisthesis, which is a fancy way of saying slip of the bone, okay? Degenerative is the most common. What happens is that these joints back here that we talked about, those facet joints, they wear out in some people over time, okay? And when they wear out, they don't do their job quite as well anymore. When that wears out and the discs wear out, which happens with age, then the slip can happen, okay? It doesn't happen to everybody, but it does happen in a lot of people. And finally, iatrogenic, which is a fancy way of saying we caused it. So as I mentioned, one of the reasons we can cause it is we're in the normal course of decompressing someone, taking pressure off. We may go in there and realize we've taken too much bone away and now we've got to fuse them. Sometimes we take bone away and they develop this instability later on, maybe not on the operating room table, but maybe a couple months down the road. We see them and they're slipping forward. And so we consider that iatrogenic, okay? Treatment for instability is almost always surgical, and fusion is usually the involved treatment, okay? Because we have to stop this bad motion, and there's not really any way to rebuild that. So spondylosis refers to, is a term referred to, used to talk about the degeneration of the spinal segment, okay? There's different terms used in the literature and in lay talk about degenerative disc disease or arthritis or spondylosis. There's all these different types of terms out there, and they, for more or less, they refer to the same type of process. That's degeneration of the spine. We try to break this down a little further. Discogenic, referring to the disc wearing out. Facetopathic, which is the facet joints, okay? And this is more for the clinicians trying to get a sense of what is causing the patient's pain, okay? Is it a disc that's worn out that's causing the pain? Is it the back? Is it arthritis back here? Not as important for you taking care of patients as to what exactly the problem is, but just I wanted to give you a little bit of background as to what can be going on in your spine. And treatments for these things have ranged from arthroplasty, which is disc replacement, to fusion, and there's lots of different ways to do these various things. We could talk for days about the different types of treatments you can do, but that's kind of the general catch-all of what would be done. So again, spondylosis is used interchangeably with degenerative disc disease. It refers to degenerative conditions in the spine, either in the disc, the facet joints, or some combination of that. And the concept is that this is causing pain, and that's why the patient's getting surgery. Again, it's kind of controversial. If you look in the literature out there and the results of surgery for people with back pain, for degenerative conditions of the back, you'll see it's all over the board. Some people do really, really well. Some people do not so well. And so we do lots of tests in the office and injections and things of that nature to try to pinpoint people we think are going to do well from this procedure. Because if we found before, when we operate on everybody that has a bad-looking MRI and back pain, the people don't do so well. So we've really kind of tried to get smarter about that over the last several years. So what are some red flags? Okay, red flags, as you might guess, means something bad is potentially going on. Okay, anytime you have a patient that's had high energy trauma, a fall like from rock climbing or a high speed motor accident, that's always a red flag. There could be an injury. Dysfunction of the bowel, bladder, or sexual dysfunction is a cue that something is potentially going on, okay? Bowel, bladder, we'll talk about that in a minute. That doesn't necessarily mean they're peeing all over themselves, which can happen, but it also can mean urinary retention. That's actually the most common, is urinary retention, okay? Sexual dysfunction would be a difficulty obtaining or maintaining an erection, or difficulty with climax. Constitutional symptoms, that means fevers, chills, night sweats, nausea, vomiting, unexplained weight gain, weight loss. Okay, those are the classic things that would suggest a tumor or infection. Okay. Progressive neurologic decline. That means I've got numbness and tingling in my arm. 2 weeks later, now I've got some weakness in my arm. 2 weeks later, I've got, now I can't hardly hold a coffee mug. Okay, now that's not necessarily always that fast. It's usually over a long period of time. But these are the types of things in general that you're going to have to kind of, so something's not right. Okay, so if you see a patient on the floor, okay, and maybe they have some weakness in their thumb, and they had that, that's why they brought them in for surgery, and now a few hours later they can't lift their arm up. That's not normal. Okay, that's something you should be going, this is not right. I need to call somebody. Possible fractures, and this is more an issue of if you're seeing someone in the emergency room. Okay, anytime you have someone with trauma, a fall or car accident, or strenuous lifting even in some cases, in the older individuals, you always be worried about fracture. Again, tumor infection, people over the age of 50, on to the age of 20, okay? Over the age of 50, the most common tumor is a MET, okay? That's metastatic disease coming from somewhere else. And so in the spine, kind of the old adage when we talk about what our differential diagnosis, what we think may be going on for tumor, it's always METs, 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 so the first three possibilities. So someone over the age of 50, we think of that. We think of the things like sarcomas and omas of some type, leukemias in people under age 20. History of cancer, obviously if you have a history of cancer, it certainly would raise your flag even more. Again, those constitutional symptoms. For infection, recent bacterial infection, so recent tooth work or dental work, recent cold, something along those lines. Obviously, people, if you're working with indigent population, you got to worry about tuberculosis, okay? Pain that gets worse when you lay down, okay? Pain in general should get better for you in your back when you're laying down. But if you're laying down, if it's waking you up at night, or it's worse when you're laying down, and that means, and I haven't cut on you yet, okay? It's a little different. If you've had surgery, you're probably gonna have some pain when you lay down. But these types of things, it's not normal, okay? And so someone should seek care. So cauda equina syndrome, this is one thing that you don't want to miss, okay? This is an important thing to kind of keep your eyes and ears open for. This is basically, the complaints are saddle anesthesia, okay? What is that? Well, you can imagine where you would sit if you were riding on a horse. All the parts that would touch the saddle become anesthetic, or the lack of sensation. So people say, I feel kind of numb, like I feel like when I wipe myself, I can't feel anything, okay? I feel like it's not there, okay? That's not normal, right? Everybody would agree with that? Recent onset of bladder dysfunction, okay? Someone was voiding on their own and they're no longer able to void. Or a common scenario potentially is you take the Foley out and they're unable to void. Now the part of the problem is, as you all know, how often does it happen that you take the Foley out and within the 6 hours you're due to void, they have to put the Foley back in? Pretty often, right? So unfortunately, just because someone can't void and had to have a Foley back in doesn't mean they have a cauda equina syndrome. So it's going to require your kind of detective powers and sleuthing to kind of decide if something doesn't seem right, we need to call the doctor. Thankfully, this is very, very rare. Okay? Matter of fact, in the last 3.5 years, I've only seen it twice in postoperative patients. Okay? And this is after hundreds and hundreds of cases. But it can happen, and those two people that it happened to don't care that it didn't happen to anybody else. Okay? They care that it happened to them. And so it's important to catch these things. Okay?